Okay, so this is part 2 of the barium series, and this is going to be a talk that focuses primarily on pathologies that occur below the stomach. So I'm going to discuss a systematic approach for looking at abnormal small bowel findings on barium, specifically with diffuse or multiple findings. So this is the general thought process that I have when I look at a barium case. I like to look at the fold thickness, whether I'm dealing with normal folds, thickened folds, and if I have thickened folds, whether they're irregular or nodular. And then I like to, so that's like sort of like pattern 1, is that a fold pattern problem. And then other things that they can show you are filling defects or bowel separation or loop separation. So let's talk about fold thickening first. There's 3 different major patterns of folds that you can have. You can have normal fold thickness, you can have thickened folds, or you can have thickened folds that have aren't smooth, they're instead nodular. And each one of these has a separate differential, and I'm going to go through it and try to explain it in a way that it can be remembered. So let's look at this first case. This is small bowel follow-through, and what we've got is normal fold thickness. This is what normal folds look like, with dilated small bowel loops. So if I would give you calipers here and tell you that this is 4 centimeters or something, that's 4 centimeters. Or you can just look at it and tell that it looks a little bit dilated. So you basically have 2 options when you see something like this. You've either got a mechanical obstruction, which is supposedly a contraindication for doing a small bowel follow-through, or you've got smooth muscle dysfunction, which is another way of saying you have an ileus. So what you're looking at is dilated diameter and normal fold thickness. And a normal fold is defined as less than 3 millimeters. Don't ever expect anybody to measure that. That's just something to have in your back pocket. If somebody would ask you, the way to remember it is the maximum diameter of a small bowel. Small bowel is 3 centimeters. So if you could just change the units to 3 millimeters and remember the normal thickness of a fold is 3 millimeters. 3 and 3. And the cause is, like I mentioned, obstruction or ileus. So this is your normal dilated small bowel. Now let's contrast it with this, and you can tell that these folds are different than the ones that we had before. These folds are too thick. This is abnormal. So this is our regular smooth fold thickening. And there's a differential for this also, so this is what we've got. So this, basically, you've got fluid infiltrating into the small bowel submucosa. It's simple fluid. It's not complex fluid. If it was complex fluid, it would look more nodular. But because it's just simple fluid, that's why it has that smooth, thickened appearance. So for the same reason that other parts of your body might swell, small bowel is the same way. So if you've got edema, so if you have like low albumin and you're swelling up, that could be a reason. If you've got hemorrhage, that's another reason also. I would expect edema to be more of a diffuse process, whereas hemorrhage is more likely to be in a focal area. So that would be how you could tell those apart. So diffuse is going to be edema, like I mentioned before, heart failure, low protein, etc. And then if you've got just a segment of the bowel that's got smooth, thickened folds, you're going to think about something that would affect just that segment. Ischemia, like watershed areas, hemorrhage, or venous or lymphatic obstruction is going to be more of a focal process, or under a certain vascular distribution. If everything's swollen, that's more like a systemic problem. So what about this guy? This is an example of nodular thickening, and you can see that that looks different also. And nodular thickening has its own differential as well. But instead of being simple fluid that's causing this thickening, it's complex. So you've got cells in there, or amorphous material, pus. And this is going to have a differential that's variable depending on what part of the small bowel it involves. So if it involves everything, you can think about lymphangiectasia, or lymphoma, or amyloid. Now, lymphangiectasia is something where it's a zebra. Basically, it's a protein-losing enteropathy. You've got blockage of your lymphatic drainage in your small bowel. You end up leaking albumin. They could tell you the patient has pulmonary edema. They could show you a picture of lower extremity soft tissue edema. And that's a diffuse process. Now, more proximal, which is going to be like your Dewey and your jejunum, you can think about lymphoma, or you can think about certain infectious processes which like to involve the proximal small bowel, Giardia and Whipple's. And if you remember, Whipple's is an infection that's seen in farmers or people that are exposed to animals or soil, and that can cause a malabsorptive or a protein-losing enteropathy as well. Distally, this is your classic Crohn's, Yersinia, TB. So the granulomatous processes tend to favor the distal ileum. TB would be the one that I would anticipate being asked. Where does TB? Where's the most common location for TB in the small bowel? Distal ileum. Yersinia is the same way also. Crohn's is the same way. Those three tend to go together with stuff. So what if there's both small bowel disease and involvement of the stomach? So in the prior lecture, we talked about this ram's horn deformity where there's a scarring appearance of the antrum. And we've got nodular thickening here. This is that granulomatous disease kind of differential that we talked about in the terminal ileum also. Crohn's, TB, and this other entity, eosinophilic gastroenteritis, can cause that. Remember that's the differential for that ram's horn deformity. So we're out of the fold thickening, and now we're into the filling defects. So filling defects come in two categories for the purpose of multiple choice. Two basic categories. We've got focal or single one, or we've got multiple or numerous ones. And there's a broad differential, but for the purpose of multiple choice, it's easier just to remember one thing. So a single target or single submucosal mass with a central ulceration target. If you see a single one, you think about ectopic pancreatic tissue. If you see multiple, like throughout the small bowel, think about METs. Specifically melanoma. Melanoma is the most common cancer to met to the bowel. What if you've got like 1 million little tiny ones? There's really only one thing that does this, and it's lymphoid hyperplasia. Again, it's one of these small bowel zebras, but the history is testable and it's classic. It's a person with severe diarrhea who has an immunodeficiency, like a common variable immunodeficiency or that absent IgA. Otherwise, it's not well understood, but that's all you would ever need to know about it. Innumerable filling defects in the small bowel, history of diarrhea, absent IgA. Now, to the last part, which is our fold separation. Like, you can imagine there was something there that's pushing these loops of bowel apart. Now, that can be from two things, two general categories. It can be from either an intrinsic process, something within the loops of bowel. In other words, the loops of bowel themselves are swollen, and because the contrast is only within the lumen, you're not seeing how thick those loops of bowel are, but you can infer that by their apparent separation. That's what I mean by intrinsic. Or extrinsic, and that would be something like a big fucking mass that's separating things. Now, how do you tell the difference? Extrinsic processes like masses or ascites that are causing bowel separation are going to spare the mucosa because the mucosal wall is normal. It's just got something on the outside pushing on it. Versus intrinsic bowel disease, which does not spare the mucosa. It's abnormal. So you can have fold thickening, ulceration, nodularity, all those things in the setting of bowel separation. So masses and ascites would be the classic two examples of things that are extrinsic, pushing stuff apart. Intrinsic examples would be things that are going to make that bowel wall thick, like lymphoma. If you've ever seen small bowel lymphoma, it's this massively thick wall. Crohn's, Whipple's, anything that causes the bowel wall to thicken, this differential would be very large. So this is an ant mini. This is probably maybe 3 or 4 ant minis in small bowel barium, and this is probably the most famous one. So let me show you the normal. This is a normal small bowel, and what I want you to pay attention to is the way that the small bowel changes. Here's the jejunum. Look how feathery that looks, as opposed to the ileum. See the difference there? Yeah, it has to do with different absorption things for fluid as the stool moves through there. The jejunum has a very feathery look. So now let's compare these two. Here's our normal next to our ant mini case. Notice that the ileum looks like the jejunum, and the jejunum looks like the ileum. They're reversed. This is a buzzword, fold reversal, for celiac disease. Now you may remember this as it's a gluten allergy, sort of gluten-sensitive enteropathy, where people who can't tolerate gluten basically end up having chronic inflammation and alteration of their mucosal pattern. They've had a long history of diarrhea. This is really common. This is very common. So the lumen is dilated. The folds are normal in thickness, but there is this reversal, fold thickness reversal, where the jejunum looks like the ileum and the ileum looks like the jejunum. Now there is a single association that's very important to know, and this is the reason why internal medicine docs will beg their patients to go on these gluten-free diets, is because celiac that is not remedied at some point really increases your risk of small bowel lymphoma. Now, the other thing to know about celiac is that you can get these transient small bowel into small bowel intussusceptions. You see those all the time anyway, just sort of randomly. But if they're showing you that if they're showing you a small bowel and a small bowel intussusception in an adult on a CT, they probably want one of two things. One, they either want you to know that it doesn't mean shit, it's irrelevant, non-obstructive, you don't need to call surgery, and it's not like that. Or two, they're trying to hint at the fact that this person has celiac. And if they're going to do that, they need to show you one more thing, which is a cavitary mesenteric lymph node or a very low density lymph node. If you're really lucky, it'll have a fat fluid level in it. So there's this entity called cavitary node syndrome that is a thing that celiac is associated with, where you've got a small or dysfunctional spleen, all these low attenuation lymph nodes, and severe villus atrophy, which would be difficult for them. They'd have to tell you that part. I don't expect they'll ask that. The point that I was trying to make was small bowel into small bowel intussusception plus low density lymph nodes on CT equals celiac. That's the other way to show it. Much more common way to show it is that fold reversal Ant-Mini. See, here's another one. This is another Ant-Mini, and this one I think is a little trickier. So I've got three of the classic findings. I'll point out which one that I'm calling the Ant-Mini here in a second. We've got pneumatosis. We've got this pseudo-sacculated appearance of the bowel. And then we've got the hide-bound appearance, which is an increase in the number of normal thickness folds. So the thickness is still normal, but there's more of them. Like it's a stack of coins is another buzzword. Lots of little, and this is an Ant-Mini for scleroderma. If you were going to remember only one of these three pictures, I would remember the hide-bound, too many folds. Normal thickness, but too many folds. Progressive systemic sclerosis is a horrific, horrible disease. It does involve the small bowel in the majority of cases. However, and this is an important point, the small bowel involvement never precedes the skin or esophageal changes. In other words, in real life, they already know the diagnosis. So if they would be hinting at you that this person's normal otherwise, it's probably not what's going on. However, I doubt they would even go there. They probably would just show it to you without any history at all. And if they were going to show you any picture, it's going to be that hide-bound appearance. So this is another classic look. It's funny looking. You may notice that the small bowel is on one side and the large bowel is on the other. Now, intestinal non-rotation or malrotation is usually a peds thing, but if they were going to get sneaky, they could show it to you in an adult patient. Now, if they ask you what surgery this patient has had, you may say this patient has had a LADS procedure, which you may remember from peds is basically a cutting of these adhesions, LADS bands, and a creating of new adhesions, basically tacking down the small and large bowel. And the reason that they do that is it's supposed to reduce the risk of volvulus, which patients that have a malrotation are at increased risk for. The other gamesmanship thing is to show the inversion of the SMA and SMV, where normally the artery is on the same side as the other artery, the aorta, and the vein is on the same side as the other vein, which is the IVC. When they have them switched like that, that is a way of showing that this person is malrotated without actually showing you the bowel. And that can be done with CT or it can be done with ultrasound. Now, if they show you an ultrasound picture and they're not nice enough to label it like I've labeled it here, the way to remember which one the SMA is that the SMA has this halo of fat around it. So this is a normal case here, and you'll see this all the time, but you probably don't pay attention to it, where the SMA is surrounded by this halo of fat, just like it is here, where you've got this hyperechoic halo. That's how you know that's the SMA. So here's a case that's demonstrating this abnormal relationship between the SMA and SMV, where they're flipped. And then as we go down here, you'll see that swirl. This is your volvulus. And that is the classic way that that's shown. So what are the associations with malrotation? The ones to remember that are pretty easy are that they tend to have diaphragmatic hernias. As the bowel's moving in and out of there, it's not other stuff's not forming correctly either, and they tend to have omphalocele, which makes sense too. So remember that the bowel is supposed to rotate, sort of protrude out, and then as the abdomen accommodates it, it rotates back in. That's like a normal thing. When it doesn't do that correctly, you have an omphalocele. All right. This is another really classic look. There is a differential for this, but for the purpose of multiple choice, this is graft-versus-host disease, or the ribbon bowel. Graft-versus-host, if you don't remember, is something that's seen in bone marrow transplant patients, where you've got essentially the graft, which is the transplant, attacking the host. And it classically involves the skin, liver, and bowel. Now, it's almost of historical context now, as the modern anti-rejection drugs are really excellent, so you don't see this as much. But the buzzword is that you have this ribbon-like bowel that is featureless, atrophic, and thickened. All right, this is the last case, and this is another Ant Mini. This is a zoom in on the stomach and the duodenum, and what I'm showing here is a cloverleaf appearance of the duodenal bulb, and that is a buzzword for a healed peptic ulcer. There's probably lots of stuff that looks like that, but there's only a few things that are like real classic Ant Minis, and this is one of them. All right, so this is the end, and we will move on to talk about, we're going to finish up the lower barium cases with the last lecture.